Friends. So today's session, good evening, friends. Welcome to yet another sessions of for NEET SS, the preparation continuation of the daily class. This is for the remnant subjects that we have not taken. We have musculoskeletal and cutaneous tumors. Today we'll be covering a bit of musculoskeletal oncology. Whatever we can cover in the next 1 hour, we'll be just going ahead with that. Okay. So without much ado, let's get on to the topic. It's soft tissue sarcomas. And usual pattern, what we are going to do the same way. It is going to be MCQs followed by the discussion on the same. And here, let me say a few things first. Like management of soft tissue sarcomas is going to be essentially by surgery. Okay, the main management of soft tissue sarcomas is by surgery. The questions that routinely come are with regard to the management of soft tissue sarcomas in terms of the most common tumors which happen. Then what is the management after a margin positive resection? So that is one question that keeps coming repeatedly. Then we have questions with regard to the role of radiation pre-op versus post-op RT. So that is one question that comes. Chemo, rarely it will be asked. And staging, the important aspects of staging also come up in the questions. So these are some things that have come. And I'll be sharing all those as a matter of routine for you. Now, the first question is, which is the most common STS and the most common location of soft tissue sarcoma? So for this, the answer is liposarcoma. If you look at it previously, the answer used to be MFH. That is why I've highlighted MFH also here. And MFH and proximal type, this used to be the previous answer. Now we know that MFH is something which is not a term which is not used anymore. Currently, the answer is going to be liposarcoma. There is no doubt with regard to this question. Don't get it wrong, my friends. It's something that's coming up routinely in many of the examinations. The most common sarcoma currently is liposarcoma, constituting around 45% of the tumor. And again, the most common location, if you look at it, that is going to be the proximal thigh. That is the upper part of the thigh. That also is around 40-45%. So the liposarcoma of the upper thigh is the most common location and the most common sarcoma that you have. MFH used to be the most common subtype of sarcomas that used to be there, malignant fibrous sarcoma. But currently, it is reclassified as undifferentiated pleomorphic sarcoma. Now the term that is used is UPS. I'll be talking about it a little bit later. It's undifferentiated pleomorphic sarcoma. The reason is previously the classification was based only on the histological patterns. So many of the tumors used to be called as MFH. Now we find that there are a lot of molecular and genetic markers which are used in staging and not in staging, in actual classification of soft tissue sarcomas. So histology alone is not sufficient. So many of these, almost 60% of what was previously called as MFH is now reclassified as other types. So that is why undifferentiated pleomorphic sarcoma is not so common anymore. Now the most common sarcoma is going to be your liposarcoma. So the most common site, as I already said, is going to be thigh, the proximal thigh. If you look at the genetic mutations, the inheritable mutations that are associated with soft tissue sarcomas, generally when we talk about previous family history, familial and hereditary inherited cancers. So here, some of the sarcomas that are associated, some of the syndromes that are there, one is your neurofibromatosis type 1. So which is a one which will be found in chromosome 17. It is an autosomal dominant disorder. You have the tumor suppressor gene. See, many of the sarcomas are going to be, many of the cancers are going to be either in terms of patients in tumor suppressor genes, or it is going to be in terms of what you can say as the oncogenes, proto-oncogenes. Okay, so oncogenes and tumor suppressor genes will be the most common thing. In this, the tumor suppressor genes mostly will be inherited only as an autosomal dominant fashion. So wherever, if you know that it's a tumor suppressor gene, but you're not sure of the pattern of inheritance, blindly you can mark it as autosomal dominant. More often than not, you're going to be correct. So in neurofibrosarcoma, you will get it as MPNST, that is malignant peripheral nerve sheath tumor. The other name is neurofibrosarcoma. Now, among the other syndromes which are going to be found is going to be your Li-Fraumeni syndrome. Li-Fraumeni syndrome is associated with multiple tumors, multiple cancers. As we all know, it is associated with the P53 gene, the master control gene, as we call it. So here, though there are multiple things that can happen, the most common cancer that happens is breast cancer. So this is a question that has been asked, which is the most common cancer associated with Li-Fraumeni syndrome? The answer is breast cancer. And again, if you take up sarcomas, the most common sarcoma which is associated is also not soft tissue. It is the osteosarcoma, which is the most common sarcoma which is associated. Other than that, you can also get, pleomorphic sarcoma. You can get your rhabdomyosarcomas. All these can happen. Then you have adrenocortical carcinoma, brain tumors. Many of these can happen. So the most common tumors in LFS are going to be, one is breast carcinoma. Then you will have the second one, which is going to be your, not second one, among the sarcomas, if you look at it, the most common is going to be osteosarcoma. This is the most common sarcoma that is associated with your LFS. What are the other tumors that are associated with the familial syndromes? One is the FAP associated Gardner syndrome, where you will have the multiple osteoid osteomas that will happen. And along with that, desmoid tumors are going to be very common in FAP. So FAP and Gardner's will be associated with the osteoid osteomas and the desmoid tumors. Now, desmoid tumors are the third most important cause of death, third most common cause of death. As far as FAP is concerned, there is one controversy in this question, whether it's the second most common or the third most common. So if you take up FAP, causes of death, the first cause is going to be colorectal cancer. There is no doubt with regard to that. The second one is either duodenal adenocarcinoma or it is going to be this one. So duodenal carcinomas are generally more common as a cause of death, in my opinion. And the third most common cause of death is going to be your desmoid. So desmoids, though they are relatively the what you can say, they are under the group of aggressive fibromatosis. They may not actually metastasize, but locally they are very invasive and it can be difficult to take control. There will be large tumors, especially if they are involving the root of the mesentery and such structures. So root of mesentery or structures like this, then it becomes a difficult thing to do. So that is where the problem of this one comes. Okay, so that is where the problem happens, and that is where you can have tumors that are going to spread, not spread actually, they are going to be basically something that cannot be cured. So that is the reason they will cause death. So desmoids as a cause of death is going to be the third most important cause of death. So usually 5 years after colectomy, they will happen. Now, when you look at the factors that predict the prognosis of soft tissue sarcomas, there are multiple things. One factor which is different in all the soft tissue sarcomas is the presence of grade, which is important. As we were discussing in the weekend classes, for example, I told you in thyroid, age is the most common, most important prognostic factor. For breast, when we talk about it, it is going to be the lymph node status, which will be the important factor. So the same way, when we talk about sarcomas, the most important factor in any soft tissue sarcoma is going to be the grade. Remember, as far as grading is concerned, all low-grade sarcomas are stage 1. All low-grade sarcomas are going to be stage 1 sarcomas. So anything which is not low-grade cannot become a stage 1. Anything, if it is even a small tumor, if it is going to be high-grade, it will straight away go into stage 2. So only the low-grade sarcomas will come under stage 1. We'll be seeing the staging in one of the subsequent slides. Now, the grading of soft tissue sarcomas is also, there are multiple systems. There are the 2-tier systems, which will be basically classifying it as high-grade and low-grade. Then we have the 3-tier systems, which will be your low or intermediate or high-grade tumors. And then you will have the 4-tier system also. So there are multiple systems which are available. The system that best predicts the prognosis among the grading systems is the FNC LCC systems, or it is also called as the Trojani system. It is also called as the Trojani system. So this Trojani system is something which is the French Fédération Nationale des Centres de Lutte contre Cancer. So this is basically a 3-tier grading system. So there are 3 criteria that will be used. One is the tumor differentiation, mitosis, and necrosis. Now, grade 1 only is low grade. Okay, just like your CA cervix, the grade 1 will be considered to be low grade. All the others are going to be high grade. Now, when we talk about tumor differentiation, mitosis, and necrosis, what do we actually mean? So we are talking about, mitosis, all of you will be very familiar. What is mitosis? And necrosis also as a criteria we'll remember. What is the differentiation criteria? Now, some tumors, based on the type of tumor that they have, based on the what you can say is the differentiation. What do you mean by differentiation? Whether it's a liposarcoma, whether it is going to be a Ewing sarcoma, based on all these factors itself, some of them will be classified as high grade. So in this, we have the high grade sarcomas based on differentiation. So this one is going to be your osteosarcoma. Then you have your Ewing's sarcoma. then you have your synovial sarcoma. All of these, whenever you hear the name itself, you don't need to mention the grade. So this is again, of course, extraskeletal osteosarcoma and extraskeletal Ewing sarcoma. So whenever you get a diagnosis of osteosarcoma or Ewing sarcoma or synovial, directly it is going to be going as a high-grade sarcoma. Directly it will be going as a high-grade sarcoma. So, write again, Ewing sarcoma, osteosarcoma, synovial sarcoma, all of these are always considered as high-grade sarcomas. All of these are always considered as high-grade sarcomas. Right. So, as I already mentioned, all G1 tumors will come as the stage 1 tumors. Now, since among the 4 systems that I mentioned here, I already talked about the FNC LCC, NIH and NCA, there is the National Institute of Health and the National Cancer Institute are also the other staging systems which will be used. Since this is something which is a consortium based thing, complex index in sarcomas. It is a consortium where they use a 67 gene platform to predict the metastasis free survival. So this is a molecular technique which has been recently found useful in sarcomas. This is being evaluated in soft tissue sarcoma. So it is a complex index in sarcomas. Okay. So as I already told you, there are a lot of mutations and rearrangements that happen, genetic mutations or translocations that happen. Now, these are taken as a factor as far as the diagnosis of the sarcoma itself is concerned. So, gene fusions happen in 30% of all sarcomas, which is very significant. Now, some of the gene fusions which are going to be always taken into consideration are this one. For example, in synovial sarcomas, we talk about the X18 translocation. We talk about the X18 translocation. X,18 translocation will happen in your synovial sarcoma. We all know about the Ewing sarcoma, where you have your EWS and FLI1. Okay, so that one is going to be the 1122 translocation. So Ewing sarcoma will have the 1122 translocation. So like that, there are multiple sarcomas for which you have a clear-cut as what you can say as the sarcomas that are dependent based on only the translocation that you're going to have. So some of the important ones I have put here. So clear cell, for example, is EWS again with ATF1. Myxoid round cell sarcomas, liposarcomas will have the TLS with CHOP. So these are some things that may be asked for you, but the most important one is going to be your Ewing sarcoma and your synovial sarcoma. These are the things that will be asked in your examinations. So grade is the most important factor for prediction and the predictive factor or the most important factor that determines the outcome prognostic factor as far as sarcomas are concerned. So when you look at the etiology and risk factors, multiple things are genetic, familial tendency, all that is there. In this, radiation takes a very important role. So radiation-induced sarcomas are going to be a common scenario. Wherever we have exposure to radiation, we develop not only carcinomas but also sarcomas. So some of the things that are very, very classically radiation-induced are the UPS and the angiosarcomas. These are two very classical things that are usually related to this one. So UPS. So the most common is going to be probably UPS. If they ask you which is the most common radiation-induced sarcoma, answer is going to be UPS. Second most common is probably your angiosarcomas. These are the two most common sarcomas which are associated with radiation. The latency period is usually 10 to 20 years. At least 5 to 10 years will be there, a latency period before the tumor actually develops. Some things that happen, most common radiation-induced sarcomas, after which radiation do they happen? Either for breast or after lymphomas. These are the two things that will happen. Now, when we talk about radiation-induced sarcoma, as we already discussed in breast, there is something called as the Stewart-Strebe syndrome, which is a lymphedema-induced sarcoma. This is an angiosarcoma that happens outside the field of the radiation. So this is a lymphangiosarcoma happening in the arm. This may be a clinical picture that will come. As we can see, it's in the upper arm that the upper limb, the patient has developed a sarcoma. It happens outside the field of radiation. It happens outside the field of RT as far as the Stewart-Reeve syndrome is going to be concerned. So if you consider the Stewart syndrome, the Stewart-Reeve syndrome, it will happen outside the field of radiation. It is not a radiation-induced sarcoma. It is a lymphedema-associated sarcoma. It is a lymphedema-associated sarcoma. It's not a radiation-induced sarcoma. Okay. Right. So these are the common questions that they may ask you with regard to radiation. Stewart Reeves is a commonly asked question. Which is the most common tumor is another asked question. So these are something. And of course, we all know about thorotrash, polyvinyl alcohol, which are used as contrast agents, and arsenic. All of these can induce the hepatic angiosarcoma as well. Right. Now going on to the next question on staging. Okay. So as far as staging is concerned, let me show the staging to you first, and then you will understand how it goes. Right. So here we have the stage of the cancer. So as I already told you, the staging, all low-grade sarcomas are going to be present as a stage 1 tumor. So stage 1 has got stage 1A and stage 1B. Okay, it has got stage 1A and stage 1B. So what is stage 1A? 1A is going to be stage 1 and T1. Okay, sorry, grade 1 and T1. T1, G1 will come under stage 1A. All other T's with grade 1 will come under stage 1B. Now, what is stage 2 then? It will be high grade. All others are obviously going to be only high grade. So high grade with T1. So you have T1 with high grade. That is going to be your stage 2. Okay. Then as far as stage 3 is concerned, it is going to be high grade in other types. So T2 with high grade will be 3A, and T3 or 4 with high grade will be your 3B. And any node positivity and any metastasis, both of these will make it a stage 4 disease. So N plus disease in sarcomas comes under the stage 4 disease. Okay, so N plus disease comes under the stage 4 disease as far as the sarcomas are concerned. Now, what is the T staging? T staging is pretty simple. Okay, less than 5, 5 to 10, 10 to 15, more than 15. So less than 5, 5 to 10, 10 to 15, and more than 15. So the T staging is pretty simple. And N wise, it is N0 and N1. Okay, so whether the nodes are positive or negative. So which are the sarcomas that are associated with node positive disease, N1 disease? So we have the acronym called RACES. So what are the things that will come in RACES? You will have the, rhabdomyosarcoma. You will have the alveolar sarcoma. Then you will have the clear cell sarcoma. E stands for embryonic sarcomas, and S stands for synovial sarcoma. So these are the sarcomas that will have a predilection for the lymph nodes. There is another slide which has all the details of the sarcomas. The listing of the sarcomas also happens. Okay. Now just going back to the N plus staging. So it's the acronym is RACES, rhabdomyosarcoma, alveolar sarcoma, clear cell sarcoma, embryonic sarcomas, or epithelioid soft tissue. Both will be mentioned. Epithelioid soft tissue sarcoma is another thing which will be mentioned. And then you will have your S, which is going to be your synovial sarcoma. And I have already told you both N1 and M1, both of them will come under N1 and M1. Both of them will come under stage 4 disease. Okay. So all low grade, basically, when it is low grade, it comes under stage 1. In that T1 with low grade is stage 1A. T2, 3, 4 with low grade is going to be stage 1B. So T1 with high grade is going to be stage 2. T2 with high grade is stage 3A, and others are going to go under stage 2, 3B. So you have 1A, 1B, 2, 3A, 3B, and 4. In this, the stage 2 is very clear. What is stage 2? You have your T1 with high grade. Okay, T1 with G2 or 3 is going to be stage 2. The same way, M1 or N1 is going to be stage 4. So what is going to be left? All the low grade. In that T1 will be 1A, and then the others will be 1B. Then you have your T2 with high grade, which will be stage 3A. That is the way you can remember it. That is the way you can remember as far as how the stage grouping will go. Because there have been questions with regard to the stage grouping as well on how to do it. So now let's go back to the question and find out what is that. So this is a 50-year-old gentleman who has an 8-centimeter tumor. 50-year-old gentleman with an 8-centimeter tumor in the anterior thigh undergoes a resection. The pathology shows a synovial sarcoma. The pathology shows a synovial sarcoma. So it is an 8-centimeter tumor. Pathology showing synovial sarcoma. Margins are free. What is the stage if the metastatic workup is going to be negative? So it is M0. Okay. And N also is 0. Okay. Other than that, what is given? The size is given as 8 centimeters. So it is going to be a T2 tumor. Now, we don't know the grade of the sarcoma, which is important to find out what is the stage. So how will you do it? Here we know that it is synovial sarcoma, which means it automatically goes under high grade. So this is a T2 high grade sarcoma. Hence the stage is going to be stage 3A. Hence the stage is going to be a stage 3A sarcoma. Okay. Right. If you look at it, the answer is stage 3A. So which are the high grade sarcomas as we discussed? Synovial sarcoma, Ewing sarcoma, peanut sarcomas. All the embryonal types also will come under the high grade. So that is why your rhabdomyosarcoma, your heptoblastomas, those kind of things, everything, whatever is a high grade embryonal type of sarcoma, all of that will come. Undifferentiated and extracellular osteosarcomas will also come under the high grade sarcoma. So you have osteosarcoma, Ewing sarcoma, UPS, and synovial sarcoma. Okay, these four essentially will come under your high grade sarcoma. So whenever you get these as the terms, there is no need to look what is the grade. And remember, as far as end staging is concerned, N1 is going to be your stage 4. Now there is a subtle difference as far as retroperitoneum is concerned. N1 will come under the stage 3B. That is the only difference in staging. All the rest is going to be the same. So N1 in retroperitoneal sarcomas will be considered as a stage 3B sarcoma. Right. So the factors in staging we already discussed. Now previously there used to be the importance of your depth of infiltration, whether it's superficial or deep to the investing layer of deep cervical fascia, grouping as A and B. This was found in AJCC 7th edition. Currently in the 8th edition, you don't have anything like that. So the only criteria you take is less than 5, 5 to 10, more than 10, and more than 15. That is the criteria that is taken. As I already said, this is the nodal spread sarcomas. R for rhabdomyosarcoma. A is for angiosarcoma and alveolar soft part sarcoma also. C for clear cell sarcoma. E is for epithelioid sarcomas. Then you have the synovial sarcoma. Lipo and MFH are also sometimes considered to be high risk for nodal metastasis. But usually the traditional acronym stands for only RACES, races, where you have your rhabdomyosarcoma, angiosarcoma, and alveolar soft part sarcoma, clear cell sarcoma. You have epithelioid sarcomas, and then you have your synovial sarcomas. All these will be the factors that will be considered for staging with N1. Now, whenever we talk about the evaluation of soft tissue sarcomas, we have to know when to evaluate because soft tissue tumors are very common. Now, in this, the important factor is the size. Anything which is more than or around 5 centimeters in size, we always need to be suspicious and evaluate it and probably advise an excision. Second thing is recent increase in size or change of size that happens, especially sudden rapid increase in size is always significant. Anything that is getting painful always needs to be addressed. And deep tumors along with recurrence after a previous excision, all of these clearly puts it as tumors that are significantly suspicious of a malignancy. Now, there are also other things that can mimic a soft tissue sarcoma. It may be a scar, it may be a pseudotumor, it may be a hematoma, myositis, benign lipomas, abscess. Many of these will be something that will mimic a soft tissue sarcoma. But, by and large, the biopsy will establish the diagnosis as far as what is the soft tissue sarcoma is going to be concerned. So, FNAC is used in soft tissue sarcoma diagnosis. Now, all of us know since grade is an important part of STS evaluation, and FNAC cannot be used to establish the grade of a sarcoma. Now, how will you then find out the grade of a sarcoma, or how will you evaluate a sarcoma? Now, in any soft tissue sarcoma, the evaluation is pretty simple. It is again the same triple assessment as what we are using in breast. Now, in this triple assessment, the clinical assessment is done first, and then you have the imaging. For extremities, the preferred imaging is going to be MRI. For any extremity sarcoma, the preferred imaging is going to be MRI because of the excellent soft tissue resolution. Now, when you are doing an MRI, you always have to compare both the limbs. So bilateral, the limbs have to be compared bilaterally. So comparison with the normal side should be done as far as the MRI is concerned. Now, in the case of a retroperitoneal soft tissue sarcoma, the preferred imaging is going to be a CECT. Here, there is not much of a role of an MRI. CECT will be the preferred investigation here you do because of the movement artifacts and the large tumors. Here, the plane is not so significant. So, in your retroperitoneal soft tissue sarcomas, the preferred investigation is CT. If they have not given anything separately and they just say what is the preferred investigation for a soft tissue sarcoma, then you can mark the answer as MRA. If they have given specifically as retroperitoneum, then the answer is going to be a contrast enhanced CT. That said, you can also use a CT of the local part for further evaluation and classification, especially for bony cortical invasion. So bony cortical invasion, and as we saw in head and neck, sometimes for cartilage invasion, all this you can do the CT of the local part as well. But the preferred modality is going to be your CT scan of the local part. Once you do the CT scan and MRI, whichever is required, after that is when you will go for a biopsy. What are the types of biopsy that you can do? You can do a core needle biopsy. Then you can do a incision biopsy. And finally, you can plan for an excision biopsy also. These are the three types of biopsies which can be done. Now, preferred today's world is going to be a core needle biopsy. Why we need to do imaging before is because in large tumors, there will be a lot of necrotic areas. There will be a lot of necrotic areas. So in a sarcoma, usually identifying the tumor or taking a biopsy from that is not very difficult. But since there will be a lot of necrotic areas, image-guided biopsy is preferred. Image-guided biopsy is preferred to avoid the necrotic areas. To avoid the necrotic areas, image-guided biopsy is the preferred modality. So image-guided core needle biopsy can be done. The other thing is you can do an incision biopsy. Now, incision biopsy, there are certain criteria. Whenever we talk about incision biopsy, there are going to be certain criteria. When will you or how will you do an incision biopsy? For this, one thing is this biopsy has to be done by the planning surgeon. Okay, the surgeon who is going to plan the surgery, he is the person who should do the biopsy. Then it should be along the longitudinal axis. It should be along the longitudinal axis of the limb, and do not cross compartments. Do not cross compartments, because if you cross compartments, let's say you have the anterior compartment of the thigh and then you have the lateral compartment of the thigh. If you cross, then you need to take the muscles from both the compartments if you have done a biopsy in a stupid manner. So that is why only the person who is going to plan the surgery should preferably do the incision biopsy also, and it should be along the long axis. Otherwise, if it is along the short axis or something like that, then we may end up doing a wrong surgery. We may need to do a wrong surgery to kind of like take out the entire thing. It may even end up with an amputation. So do not cross compartments. That is one thing which is going to be clear. Now, as far as possible, avoid hematomas. Avoid hematoma and get good hemostasis. There should be good hemostasis. Now, the reason why this has to be stressed is because if there is a hematoma, that will form a good nidus for tumor growth. That acts as a nidus for tumor growth. And that is why excellent hemostasis during even an incision biopsy is going to be very needed. And use of tourniquet is preferred. Along the same lines, use of tourniquet is going to be preserved. The only thing that we need to remember is exsanguination is forbidden. Forbid exsanguination. For people who don't know the term exsanguination, what it means is, like, suppose I have a tumor which is there in the right arm. So then you will generally lift up, you will take out the blood, then you will apply the tourniquet. This procedure is called exsanguination. This should be avoided whenever you are planning the tourniquet for a sarcoma, because that can cause propagation of the cells from the tumor and spread it to the central circulation. So exsanguination of the arm should be avoided, and you have to go in the shortest path as far as possible. The shortest path should be taken with a the requirement of the incision should be again as short as possible along the longitudinal axis and along the planned line of future incision. Along the planned future incision, like that, it should be done. And biopsy is one of the most important things that needs to be planned and done as far as the soft tissue sarcomas in the incision biopsy. So this is with regard to your incision biopsy. So when will you actually plan for an excision biopsy? When will you actually plan for an excision biopsy? Now, excision biopsy, on the other hand, is required for relatively small tumors, somewhere around the 3 to 4 centimeters or up to 5, where you have a suspicion. So you can straight away plan for a excision of the tumor itself with margins. Grossly margin of at least 1 centimeter is advised in any kind of sarcomas. There are some for which a margin of 2 centimeters will be preferred. For example, like DFSP, at least 2 centimeters. Okay, it should be at least 2 centimeters. There are some will say even 3 centimeters needed for a DFSP, but at least 2 centimeters should be given for some tumors. In general, grossly, you should have a margin of 1 centimeter. So these are some of the points as far as the management of or the biopsy in soft tissue sarcomas is concerned, right? So since we know that only biopsy is the management, so where can we use an FNAC? It can be used in STS diagnosis in what? In stage, in grade, in mitosis, or in recurrence. Where can we use it? The answer is obviously in a recurrent scenario. So where you can have a patient who has been already treated for a soft tissue sarcoma and then later come back to the recurrence. At that point of time, you can consider going in for an FNAC alone to confirm the diagnosis. Stage usually cannot be identified by an FNAC unless it is at a metastatic setting. Same thing, grade and mitosis are not going to be very well differentiated by using a FNAC. So the only option here is going to be a recurrence. So used only in detection of local recurrence. Sometimes we can find out the node and distant metastasis. This is where rarely we can use it to stage, especially when distant spread is there, you can find out the stage. But otherwise, it is mainly used in terms of local recurrence. So as I already said, the image guided core biopsy or an incision biopsy needs to be planned. And imaging before biopsy, MRI of the local part in extremity, CECT for RP sarcomas, and as far as staging is concerned, CT of the chest for lung metastasis is mandatory. So core needle biopsy is the minimum. You will get the grade of the tumor. So where is the use of FNAC? Only in scenarios like nodal status, metastatic status, and in terms of recurrence, this is where we'll be using the FNAC. And as already we discussed, this is the principles of biopsy: longitudinal incision within the planned later excision site, tourniquet control, and no exsanguination. Okay, and anatomical compartments do not cross the compartments, do not contaminate vital structures as well. Okay, and pathology. And imagine one more thing that is significant is going to be that you have to have a sample, fresh samples, which may be needed for cytogenetics. Okay, so for studying this mutations, for studying this, what you can call as this fusions, all of this, you will need to have a fresh sample as well. So preserve it fresh. One part you can keep it as fresh, other part you put it in formalin as well. And generally, when it is not clear what is the diagnosis, have some samples sent for microbiology as well. This is especially true in places where it's retroperitoneum and all that, where it may be a nodal disease due to tuberculosis. So such places you may need to go for a fresh sample to ensure that you're not dealing with tuberculosis. So these are things that you will need to plan and do as far as a biopsy is concerned. So the gross management is given as a tabular column as far as subsystem is concerned. I'll come back to that a little later. Okay. Now, when you think about lipoma versus liposarcoma, now we are going into specific sarcomas here. So when we talk about lipomas versus liposarcomas, on imaging, we'll find some features. On imaging, there will be some features which are more suggested with the risk of liposarcoma as compared to a lipoma. So which feature does not support a liposarcoma? So thick septa up to 2 millimeter, more than 2 millimeter, size more than 8 centimeter, presence of non-adipose areas, less than 75% adipose tissue. So which of it is not associated? Now, some things you can actually rule out pretty simply. So non-adipose areas, whenever you find, that is suggestive of a necrosis or some other areas which are becoming different. So this is more likely to be a liposarcoma. Okay. And the same way, less than 75% adipose tissue is more indicative of some other thing. So these two, C and D, you can clearly rule out as options because these two, say that the diagnosis is more likely to be your liposarcoma. And as far as septations are concerned, again, lipomas are unlikely to have septa, or even if they have septa, it will be less than 1 millimeter. Thin septa are likely to be there. So thick septa is clearly a feature. So just by thinking about it, you can rule out and you can say that the option is going to be only size which is more than 8 centimeters. So only that is the feature which is not suggestive of a liposarcoma. That is the only feature which is suggestive of a lipoma. But even here, size is taken as a criteria. But only thing is the size criteria is more than 10 centimeters. Size more than 10 centimeters is suggestive of liposarcoma. Thick septa more than 2 millimeter, non-adipose areas, and 75%, less than 75% adipose tissue. All these are something that suggests that it is more likely to be a liposarcoma rather than a lipoma. Now, most common STS is, again, as we already discussed, is liposarcoma, and it is also the most common STS in the retroperitoneum. In fact, 45% of all retroperitoneal STS is again liposarcoma. So in liposarcoma, we have this 45%. Most, among all sarcomas, LPS constitutes 45%. In all RP soft tissue sarcomas, it constitutes 45%. And again, in all what you can say as the sites, proximal thigh is going to be around 45%, which is essentially your liposarcomas. Now, when we talk about lipomatous tumors, there are three varieties of liposarcomas that we have. One is your well-differentiated liposarcoma, which is grouped as your ALT. So it is usually called as ALT/WD, well-differentiated liposarcoma or atypical lipomatous tumor. Both of them cannot be clearly differentiated in many scenarios. This is the most common subtype of your liposarcoma, associated with an excellent prognosis, and there is no role for any adjuvant radiation as far as these sarcomas are going to be concerned. This is just managed by a wide excision. Now, in this, there is a specific mutation which we call as presence of MDM2 upregulation and CDK4 mutations are going to be found. So this is going to be common in your well-differentiated liposarcomas or ALT. Now there are also MDM2 inhibitors which are coming in. So this is something which is significant as far as an MCQ is concerned. So MDM2 and CDK4 being wrong or upregulated is going to be found in your liposarcoma. In pleomorphic liposarcoma, that is the second most common type. It has got the worst prognosis. Wherever you hear the term pleomorphic, usually it is going to have a poorer prognosis, and that's the same that applies to your liposarcomas as well. So tumor will be hypervascular. There will be areas of necrosis and cystic change, features of adjacent organ invasion, and areas of focal nodularity. Okay. Now in this picture, if you look at it, this is how on the picture on the left, you will have the pleomorphic liposarcoma. So you will find some areas which are going to be like this, where you're going to have this area. If you look at it, this is the fat density. In the rest of the areas, what you have, that is your fat density here. Whatever these areas are, that is the fat density areas. Whereas you take up this particular area here, that is hyperdense. So this area will be hyperdense and hypervascular. So areas of dedifferentiation and nodularity, that will be there in your pleomorphic liposarcoma. And then you have the third type of liposarcoma, which is going to be your myxoid and round cell liposarcoma. You will have the myxoid and round cell liposarcoma. Now, as far as the myxoid and round cell liposarcomas are concerned, this myxoid round cell liposarcomas is the least common type. Okay, they are the least common type, and they are associated with they are the least common type. Among the sarcomas, among the liposarcomas, they are the least common type, and they have the first DDIT rearrangement. Okay, so DDIT3 first or EWS1 with DDIT3, that is the rearrangement, chromosomal rearrangement that you will find. The characteristic feature of myxoid and round cell is exquisitely sensitive to chemotherapy and radiation. As I already told you, there is no role of radiotherapy or chemotherapy or radiation as far as your liposarcomas are concerned in ALT and WT. That is the well-differentiated or ALT types. There is going to be no role of it. But when you take up your myxoid and round cell, that is the kind of like exception to the rule. These are highly, aggressive tumors, and hence because of this, they'll be sensitive to chemotherapy and radiation. And in this, again, the round cell type will again have the poorer prognosis. So overall, the worst prognosis, when you look at it, is going to be for pleomorphic sarcoma. The worst prognosis is going to be for pleomorphic sarcoma, and myxoid and round cell are associated with the chemo and radiosensitive nature. Now, what is the management? Generally, whenever we talk about it, we have to talk about the management. For all sarcomas, clearly it is a wide margin negative resection. Okay, so it is a wide margin negative resection. If you can do a compartmental resection, then that is okay. Now, in retroperitoneal liposarcoma, we cannot really get a margin negative resection. There will be areas where the margins are likely to be compromised as far as the retroperitoneum is concerned. There is a role of considering compartmental resection in retroperitoneum, where, for example, there is a tumor which is sitting in the, let's say, in the right iliac fossa, they may, in the right lumbar region, they may consider removing along with the nephrectomy and along with the colectomy, ascending colon. So right hemicolectomy, right nephrectomy, all this might be done. There is actually a group in Italy which has done it, and which has showed that there is a higher survival in disease-specific survival, but overall survival, there was no difference. So this is still controversial. In many sarcomas, you will actually find out if there is an invasion, if there is an invasion or not. So current guidelines only indicate that if there is an invasion of surrounding structures, we have to plan for excision of the surrounding structures. If there is no invasion, then there is no hard evidence so far that there is going to be a role for going in for resection of these tumors. There is a currently you just do a wide margin negative resection. That is all is mentioned in most tumors. Now for dedifferentiated types, you can consider whenever you have this pleomorphic, dedifferentiated, myxoid round cell, all this you can consider going in for adjuvant radiation. Now, recurrent retroperitoneal tumors, so the growth less than 0.9 centimeters, and so they have a better outcome. And tumor growth of more than 0.9 centimeters is associated in retroperitoneal sarcomas with a poorer outcome in retroperitoneal soft tissue sarcomas. Other point of advanced liposarcoma is there's a specific drug called eribulin. So this particular drug can be used in the advanced liposarcomas. Now, when you consider your sarcomas, liposarcomas, there will be a role for giving neoadjuvant chemotherapy also when you consider it might be a pleomorphic or not pleomorphic, especially for the round cell type, myxoid round cell type we can consider, and pleomorphic also sometimes we can consider. So in the high grade sarcomas, in the high grade liposarcomas, you may consider putting the patient on neoadjuvant chemotherapy and then following it up by excision. So regarding radiation in soft tissue sarcoma, now this is a question that has come up time and again. So which is the preferred mode of radiation? When will you go for radiation? In short, we can just think of it. If you look at the management slide, that will become a little clearer for you. So in management of a patient, history physical, then you have CT and MRI, biopsy is done. You go for the staging dependent on the size, shape, grade, etc. Then, if it is a low-grade sarcoma, gross classification itself depends on whether it's a stage 1 tumor or otherwise. Low-grade means it's a stage 1 tumor. So, if it is a low-grade sarcoma and a function-sparing complete resection is possible with negative margins, then you go for excision. So, in a low-grade sarcoma, the predominant treatment is going to be by excision. If margin negative status is achieved, then there is no further adjuvant therapy. If you have microscopically positive margin, then you may consider going in for post-operative RT. Now remember, one point is this is something that has been asked again and again in the examinations. When you have a margin positive in a sarcoma, what will be the further management? So in a margin positive status anywhere, generally re-excision is the preferred modality if feasible. So the option should be always re-excision if it is feasible. So you have to look at the scenario. Some cases they have clearly, the scenario will be mentioned. If nothing is mentioned and re-excision is there in the options, then you have to choose re-excision as the first option. Radiation will be given in the adjuvant therapy, but if re-excision is given in the options, then re-excision is always preferred. Now, why it is not always feasible is suppose a patient has a tumor in the thigh. Okay, so you have a patient who has got a tumor in the thigh, somewhere in the knee joint, there is a proximal sarcoma. This has been resected, and after that, they say it's a focal margin positive tumor. It is a focal margin positive tumor. So in such cases, where will you go and resect the margins becomes difficult. So unless the tumor is mapped out particularly and they say the superior margin is positive, inferior margin is positive, entering the whole cavity may be difficult. But sometimes re-excision can be done even in these scenarios. In fact, in all extremity sarcomas which have undergone an unplanned excision, always it is better to re-excise. It is better to re-excise in case of an unplanned excision with wider margins. So re-excision in all unplanned tumors is done as a matter of routine. So in margin positive, if the option is given as re-excision, always choose re-excision as the option. It is very clearly mentioned inside the text in Sebastian also. Of course, in the adjuvant scenario, sometimes we'll add on radiation if you're not sure with regard to the margins. Where the margins are, if you're not sure, then you will consider going in for radiation. But in general, whenever you have a margin positive resection, re-excision will be the first choice that you have to do. Now, if you consider the high-grade sarcomas, here again you look at the size of the tumor and what is the type of tumor that you have. So whenever you have Ewing sarcoma, whenever you have embryonal sarcomas, whenever you have rhabdomyosarcoma, and whenever you have your myxoid pleomorphic sarcomas, like for example here, round cell and your myxoid pleomorphic liposarcomas. So all these, essentially the chemosensitive varieties of sarcomas, whenever you have, in all these cases, you have to consider going in for pre-operative chemotherapy. So which are the chemosensitive types? Essentially, it's going to be the Ewing's group of sarcomas. Then you have your pleomorphic or round cell liposarcomas. Select cases in other scenarios, like even for example, extraskeletal osteosarcoma. Whenever you have an extraskeletal osteosarcomas, all these are places where you will consider going in for a neoadjuvant chemotherapy. So I mentioned about the high grade, no, similar is going to be the same group, Ewing sarcoma, extraskeletal Ewings, and extraskeletal osteosarcoma, and again your myxoid or round cell or pleomorphic liposarcoma. All these cases you can consider going in for neoadjuvant chemotherapy. You have to go for neoadjuvant chemotherapy. And even in a high grade, suppose it is a very small tumor, less than 5 centimeters, basically a T1 high grade stage 2 tumor, then you can usually excise it with good margins. So function sparing excision will be feasible. Between 5 to 10 is doubtful, but more than 10, definitely you should consider preoperative chemotherapy. And after that, you have to go for excision. So where there is an indication in high grade sarcomas, when the tumor is high grade, and again when it is more than 10 centimeter, definitely consider going in for neoadjuvant. And after that, you plan for an excision. So wide margin negative resection. What should be the margin? 1 centimeter. So if you have clear margins of 1 centimeter, if there is a small tumor, again there is no role for any adjuvant therapy. On the other hand, anything where the tumor is more than 5 centimeter, then you have to go for post-operative RT. So this post-operative RT can be either brachy or it can be IMRT, but usually IMRT will be used in the post-operative scenario. IMRT stands for intensity modulated radiation therapy, or EBRT, as we already discussed in the head and neck chapter. Okay, so it is a form of EBRT. So in short, when you have a low-grade tumor, essentially the management is by giving surgery as the first option. If there is a margin positive status, go for re-excision and then you give on RT. Okay, so management for sarcomas is going to be pretty simple. Low grade, you plan for surgery. Whenever it is a low grade tumor, management is by surgery. And sometimes you will, if it is margin positive, then re-excision, and then you will plan for RT in case of margin positive status only, right? So this is as far as the low grade tumors are concerned. When it is high grade, when you have a small tumor, straight away plan for surgery. Margins are negative and it is a small tumor, you can observe the patient. All other scenarios, generally speaking, you will have to go for adjuvant radiation. In short, what is the role of RT as far as are concerned? Any high grade tumor which is more than 5 centimeters, usually deep tumors, all these will be indications for going in for radiation therapy. And of course, whenever it is going to be margin positive status, all these are going to be indications of radiation therapy. What is the role of neoadjuvant chemotherapy? When you have a high grade chemosensitive type like Ewing's or osteosarcoma, or you have a round cell pleomorphic liposarcoma, all this when you have, that you will consider going in for neoadjuvant chemotherapy. All other cases you will plan for excision, wide excision, with at least what is the margin? 1 centimeter margin should be achieved. If the margins are less than 1 centimeter and all that, then definitely you will have to consider for post-operative RT. Now there is a role for chemotherapy in the post-operative period as well. So whenever you have extremity soft tissue sarcomas, whenever you have your extremity soft tissue sarcomas in large or high grade tumors, you can consider going in for adjuvant chemotherapy also. You can consider going in for adjuvant chemotherapy also. I think that will make the management quite okay for you guys. So I'll repeat it once more. So low grade sarcomas management is a wide on block excision. Low grade sarcomas, the management is going to be a wide excision of the tumor. On the other hand, whenever you have a high grade sarcoma more than 10 centimeters, especially if it is associated with the Ewing's, osteosarcoma, or mixed pleomorphic sarcomas, that you will plan for neoadjuvant chemotherapy. Otherwise, you will still plan for wide excision. Then after this is done, in tumors which are less than 5 centimeter, you can still observe. Anything more than 5 centimeter and high grade, usually radiation will be given as an adjuvant therapy for these patients. So I think that makes the management clear for you. So now going on to radiation, how can radiation be given? So neoadjuvant radiation or adjuvant, there is a role for something called as pre-op radiation as well. That is the question that is coming here. So this radiation, whenever you have a necessity for giving radiation, suppose you know in the biopsy that it's a high grade sarcoma, and you know for sure the size is more than 5 centimeters, then you know for sure that the patient is going to need radiation. In this scenario, will you go for pre-op RT or post-op RT? Now, there are definite pros and cons of giving both, but in essence, the preferred scenario is to go for pre-operative radiation. Why we can give pre-operative radiation? Neoadjuvant RT is the preferred modality because one, intact blood supply is going to be there. And for radiation, you need to have a good blood supply and good oxygenation. Good oxygenation is also required. Good blood supply is also required as far as RT is concerned. So when it is a preoperative setting, that will have a good blood supply without any scarring. So that is the preferred mode. So oxygenation, and it will have a good blood supply. Second thing is, generally speaking, if you have a tumor, let's say like this, in this kind of scenario, you have a tumor which is here. Okay. Now, when you want to give margins for this tumor, you will go for margins like this. So around 1 centimeter, you can go and you can give the margin and you can come. On the other hand, in the post-operative scenario for the same patient, you will have the scar which will extend more than this. Now, this will be taken as margins. All around 1 centimeters are given. So the scar will be like this. Now, where will be the planning which will be done for radiation? That will be done around it for about a centimeter. More than that, it will be done for 1 centimeter. So when you have it like this, then it will be something like you need to go for extra margins. Beyond 1 centimeter, you have to go another 1 centimeter. So whenever you are giving post-operative radiation, the field will be much larger. So the advantage of giving pre-operative RT, the other advantage is going to be there will be a smaller field of RT. Okay, so there will be a smaller field of RT and there will be an accurate mapping. In the post-operative scenario, there will be a lot of edema, induration, all that in the surrounding areas. So we will not know which is the affected area. So we have to give much wider margins. So in essence, whenever we know for sure that radiation is indicated, the preferred modality is neoadjuvant radiation because of good oxygenation, intact blood supply, accurate tumor marking, and a smaller field of radiation. The only problem is there is going to be more of wound complications. Wound healing will be affected when we give a preoperative RT. But that said, even if it takes a much longer time, we can manage it conservatively. On the other hand, when we do surgery and after that there is wound healing problems, which happens in large sarcomas whenever we deal, especially in extremity, where the wound healing may not be proper, there will be a delay. There is going to be a very, very significant delay which will be caused whenever you are going to deal with these patients in the post-operative setting, which is going to be deadly for the patient. It may take much longer time. On the other hand, even if wound complications happen in case of neoadjuvant RT, it doesn't matter because the patient is still going to have a pretty good time for it to heal. There is no hurry for giving any further therapy. Now, we all saw in breast, for example, that complete pathological response is important and that will have a better prognosis. But unlike in breast, in neoadjuvant radiation, it does not have any effect on the prognosis. Now, margin status, as I already mentioned, should be at least 1 centimeter, 1 to 2 centimeters beyond the pseudocapsule of the tumor. And as I already said, positive margins, we have to go for re-excision to achieve a 1 centimeter margins. This is given in Sebastian also. So let there not be any confusion, my friends. This has come multiple times. When there is a positive margin, if re-excision is given in the options, you always mark re-excision as one of the options. Okay. So I will close the session with this today. We'll continue either tomorrow or day after. I will update you. The doubts also you can put up in the group, my friends. I'm a little pressed for time today, so I'm just closing the session with this today. Most of the gross management we have covered. We'll be talking about the other sarcomas as well in a session either tomorrow or day after. We'll be having it. It will be a longish session. Okay. Thank you, my friends.